Hello, OT students. Bridget Scheidler here. I'm going to record the lectures for that we were supposed to do yesterday in class. There's two PowerPoints that go with it that should be on Moodle. One is writing S.O.A.P notes, and the other one is writing goals. My goal was to get the S.O.A.P notes done yesterday lecture for you, but my 2-year-old developed a fever while my husband was putting up hurricane shutters, so I apologize about that. I will I'm trying to get the S.O.A.P note lecture done now. It's very didactic, which means boring, so I apologize about that. I'm just reading a lot, adding some extra info. If I can think of anything witty, I'll add it in, but my brain isn't functioning at the highest level right now. But here you go, and if it's choppy, I apologize. My 2-year-old's sleeping upstairs right now. So here we go. We're going to talk about the S.O.A.P note, and S.O.A.P is an acronym for Subjective, Objective, Assessment, and Plan. And a lot of healthcare professionals use a S.O.A.P note. It's just not unique to occupational therapy. As you can see, this was Dr. Giles' lecture from last year, and I didn't have too much time to practice, but I'll do my best here. It's very, this is concrete information, so hopefully it won't be too difficult. The S.O.A.P note heading, you want to include, the name, the date of birth, medical record number, date. All this heading stuff is actually, especially these days, more auto-generated. So you don't really have to memorize this list, but just know that this is the most, health information from clients that's usually on the top of all medical record notes. If you are working with an old school system that is handwritten, sometimes you do have to add this in. And at the very least, you need the name, date of birth, medical record number, and date. Those are always, when I was on paper, you had to put those in. And then usually on the evaluation forms, you would add the gender, occupation, race, religion, diagnosis, insurance, occupational profile. Well, we talked about the occupational profile on the second day of lab, so I'm not going to go into that too much. We have another slide on it. But we know you don't always write it all out, but it's part of your evaluation as a whole. And then I want you guys to think about, we talked about this randomly in classes with examples, why religion might be a very important profile information to put on your patient's medical record. It is very important, and I'm not going to answer that. I just want you to ponder that and think about why it might be important. So here's the occupational profile. Again, we already talked about this. Medical, social history, prior level of function. Those are those 4 or 5 questions. Who is the client? What are their goals? That's in a prior lecture that we gave you on the second day. Their social history, their hobbies, and their interests. So this isn't necessarily just a 2, 3, 4 paragraph occupational profile that you write, but it's incorporated throughout your evaluation. We talked about the only one that I can think of that you might actually be writing an occupational profile where, writing paragraphs is there are some pediatric evaluations, such as the sensory integration evaluation, at least when I did it 10 some years ago, that you did write out an occupational profile. So again, we're not talking about the evaluation here, we're talking about the S.O.A.P note, which is basically the treatment note for each treatment session with your client. So the S is the subjective. It's the client's views. It's what are the client's comments? What are their perceptions? What are their complaints or problems? And always use quotations when available. Always use a direct quotation when available. Patient seems to be depressed. It really belongs more in an assessment, where if they say, I'm depressed, that belongs in the subjective. It's a very important statement because depression is a symptom that needs to be addressed, especially if it wasn't seen or diagnosed before. But you want to be careful of how you word it. So patient seems depressed would be an assessment. That's kind of what you gathered throughout your whole treatment. Mr. Smith just seems a little depressed today. Or Mr. Smith seems depressed when performing ADLs, etc. That would be assessment. But if he stated right when you saw him, I'm depressed, that belongs in the subjective. It's a direct quote. Well, what if a client is nonverbal? you can write about gestures, and this happens a lot, gestures, nods, smiles. You know, it doesn't have to be exactly a quote. A quote is preferable. I've even written sometimes for my nonverbal clients or just significantly decreased cognition, quotes from caregivers. That's important because we're addressing caregiver burden so much in occupational therapy that a quote from the caregiver is also okay, but make sure that you're saying it's from the caregiver. And a side note, caregiver is usually abbreviated CG. And make sure it's relevant on your topic of your note. Just don't write about the weather is making the client's knees hurt if you notice this during meal prep. So make sure it's relevant to what you're working on and your client. So let's go over some examples here. So which statements out of these 6, I'm going to give you a minute to look them over, which statements belong in the S section? And I'll give you a little hint. 2 do not belong in the S section. So maybe think about that way. Think about 2 that just you don't think belong in that subjective section of the S.O.A.P note. Okay, and here are your answers. So the ones in red that appear red here, the client said she's hearing voices telling her to cut her hair. I am fat and ugly. Client is nonverbal but smiled throughout treatment. And client's goal is to get back to normal in quotation. Can all be part of the subjective part of your S.O.A.P note. Now, Lisa got dressed by herself today, and Mr. Smith appeared tired and listless. Those would belong in the assessment part. Actually, the Lisa got herself dressed today you could put in the objective part too, because that's something objective that happened. It's factual, so we can talk about that in a minute. But they can both appear in the assessment part too. And I know you guys are probably like, why was I'm fat and ugly an example? Should you include that? I think that's a very important direct quote to conclude, especially if you're thinking this person is depressed or needs counseling for something. Depression is very common after an injury. Think about how sedentary people are when they have surgery or an injury, especially if they had a more active lifestyle before. So if you're suspecting some psych issues, it's definitely important to write down subjective statements like that to defend why you might be recommending counseling. And again, so nonverbal, the part Mr. Smith appeared tired and listless, we talked about that. That should be in the objective. If you put number 4 in the objective, I would just word it differently. I would say patient donned shirt and shorts independently. That's much more professional than saying Lisa got dressed by herself today. So that's the subjective, and we're going to move on to the objective. And honestly, I wanted to add that subjective can sometimes be the hardest part for a lot of students and novice clinicians in S.O.A.P notes. It's the most direct and the shortest, but it can be the most difficult. So hopefully we'll have time to talk about that in class, but just getting something that's relevant and subjective in that subjective statement. There are many times when you're working with clients where it's very easy to write down something subjective they said in relation to your treatment, either positive or negative. I'm having a really hard time, Bridget, working with that reacher, or that grab bar worked so good, I felt so much safer taking a shower yesterday. Those are easy subjective things to write down, quotes to write down for your S.O.A.P notes. But sometimes it can be a little more tricky to pick out. So just think about that. Don't bypass the subjective and think it's the easiest part. It's something to really you have to listen for and think about what's relevant to your S.O.A.P note. So let's move on to the objective. So this is, again, objective. It is what it is. It's what did you observe and measure. A lot of functional tests are here. ADLs, oh, it's right there. Ambulation, transfers, balance, range of motion, strength, sensation, perception, cognition. All of that stuff that we're objectively testing and objectively grading belong in the objective part of your SOAP note. Always include with where, why, and how long. Options for organization, order of events and sequence, uses of categories, use of chart. I'm not really sure what use of chart means here, so hopefully I can figure that out for you guys. But objective is, maybe the patient performed a stand pivot transfer from the wheelchair to the toilet with min assist, including manual cues from the therapist for safety and use of grab bars 3 times before becoming fatigued and needing a therapeutic rest break. So why? Obviously the why is there. Why is because they need to go to the bathroom. For how long? It's not. You don't always need to include these 3. In my opinion. But maybe I'm reading this wrong. We'll get to some other slides later. But include as much detail as you can, but as concisely as you can. Some SOAP notes therapists write are just too long. They're going to get overread. You want concise and detailed. So again, that's another really hard part to pick up, is you want a concise and detailed SOAP note of the objective part that you did. And that's why like range of motion, you can 0 to so many degrees or negative something to so many degrees in what extremity. And you might be writing for what ADL the person needs to improve the range of motion for. And I'm trying to think of an example for that. So the patient had difficulty reaching into the upper cabinet to grab a glass of a water cup due to decreased range of motion in the right upper extremity, in the right shoulder flexion measured 0 to 60 degrees. And then you'd get more into the assessment there after we talk about that once you measure it. So actually a better way to word that for the objective part is patient required moderate assistance to obtain a water glass from the cabinet due to decreased range of motion in her right shoulder, which now measures 0 to 60 degrees of active range of motion. Oh, here's a better example, probably. Okay. Client seen in OT clinic times 40 for 45 minutes to increase right upper extremity, active range of motion, and donning shirt. Client participated in right upper extremity exercises with minimal cues to follow non-weight-bearing precautions. Client took 3-minute rest break after exercise. Then client donned shirt with minimal assist using compensatory methods. So that's a great little paragraph objective. In my mind, I was thinking of the most recent SOAP notes I did where it was more simple sentences versus a little paragraph. And it, again, as Scott was saying, depending on where you go, you're going to be writing SOAP notes a little bit differently, or documentation a little bit differently everywhere you go. And this is a great objective. Reads very well. It flows well. The only thing I would do here is I would add client took 3-minute therapeutic rest break after exercises. Medicare and many insurances don't pay for your patient to just sit there and take a break. But if you add therapeutic rest break, that is saying they need a therapeutic rest break. You are checking, and then I would defend that, saying pulse rose from 80 beats per minute to 120 beats per minute, requiring 3 minutes to decrease to normal levels, or you add their respiratory rate. So why did they need that therapeutic break? I think that's very important to put here for audits with insurance. Okay, here's another objective example into categories. So, which is kind of what I'm used to. Client seen in clinic kitchen for skilled instruction in a cooking task. For their mobility during that task, maneuvered in kitchen, mod-I in wheelchair. Upper extremity range of motion and strength was within functional limits for reaching for items in drawers, opening refrigerator, and opening can. Activity tolerance took 3-minute break after 20 minutes. Again, I would defend that more. And cognition, patient able to respond to verbal instructions and simple questions with correct response 3 out of 3 times. So if you're writing that for upper extremity range of motion and strength, it's a great thing to write within functional limits. So their strength and their range of motion was just fine for completing that skilled cooking task. Would you do any range of motion or strengthening exercises for that client that day to improve the cooking task? Think about that. And then with the cognition, patient is able to respond to verbal instructions and simple instructions with correct response 3 out of 3 times. Same thing. So they're saying that the upper extremity range of motion, strength, and cognition was both within functional limits and didn't need any assistance for this task. So you don't, in the assessment part, which we'll get to, unless there's other areas of occupation and goals that are not within functional limits, within strength, range of motion, and cognition, you cannot bill to work on it if it's within functional limits. So it's great that you've worked on it, especially if you're working with multiple therapists, for them to know, hey, this is fine now, you don't need to work on it. But you can't bill for working on something that the client can do on their own. I hope that makes sense. So it is needed that you document it, but make sure that you show that your time spent with the patient was with skilled treatment. Now, if it was the first time within functional limits, that could be, there's a little gray area there if they needed so much help before. And again, maneuvered in kitchen moderate independently. So this, I'm taking this all in here, and the only deficit this client has on this specific activity would be activity tolerance, which I usually refer to as cardiovascular stamina or CV stamina. So that's what you were really working on in this test. I wonder if I can highlight this. Right here is where your skilled intervention came in. So again, I would defend that activity tolerance more and why the client needed a 3-minute break. And were they standing? Were they sitting? You want to get really objective in that. What was going on? What was the factual situation going on during this cooking task? So they were in a wheelchair. So excuse me, it's already said that they were in a wheelchair. Maybe how much they were maneuvering around. So you want to look at the whole picture. If this said completed the task in 20 minutes with no rest break, there is nothing that's skilled that you're really working on there then that has been stated in the objective. I'm not saying it didn't happen, but you really want to look at what was stated and where your skilled intervention came in. That's the most important part of the objective. And I hope that makes sense. Again, reach out to us with any questions. Okay, and here's another example of the chart, and I guess I just didn't read through this clearly enough. I have used charts in the past. They're usually automated within many EHRs, which is electronic health record systems. So they're therefore more black and white areas such as range of motion and manual muscle testing. So the shoulder flexion on the right, on the left, what's their range of motion or their joint motion here? So you put 0 to so many degrees, or 10, if they don't have full extension, maybe 10 to 50 degrees, extension to abduction. So this is what a chart looks like. You will see this a lot in a lot of EHRs. So something to get used to, but it's actually much easier than writing it all out. So charts are great. Okay. And then, here's an example of electronic chart, which I think you guys are mandated to do the CARES clinic now. So you're getting used to that in WebPT. So that's great practice. WebPT is very widely used. And so, but they all are not created equally. There's no perfect electronic health record system. But definitely play around with that and volunteer with CARES as much as you can for that experience. It's really great. So that's it for the objective part. You can press pause if you need a little break here. So we just need to go over the assessment of a S.O.A.P note, the A, and the plan of a S.O.A.P note, the P. So the assessment is analysis of a S.O.A.P note. So you're not referring to like assessments, like the functional measures you're taking or the evaluation assessments. It's the analysis. It's your skilled therapeutic thinking of the subjective and the objective. You're kind of putting everything together. You think of the analysis. So AA, it's not assessment. The A is more of an analysis here in that sort of form of assessment. So the A includes a list of patient strengths and weaknesses. It can include, it doesn't have to include all this depending on what you're working on. Progress or lack of progress towards their functional goals, that's usually always included. Rehab potential, your overall opinion on whether or not OT is realistic and or appropriate for this patient. And that can be kind of integrated in your progress. If you say the client is performing well towards long-term goals, has reached short-term goals 1 and 3, with potential to reach long-term goals, because those are usually integrated in the same sentence or two. And then it can also include your recommendations for equipment and other services. As we were talking about psych, social work is SW. I've also seen that, saw that in another, I'm trying to help you guys out, in another there's another letter for social work too. I'll try to remember that. And then SLP is speech language pathologist and physical therapist. So this is the most important to make an impression on the reader. This is your professional judgment. This is your skilled professional judgment based on the response, the subjective from the client, how they are feeling towards their progress, and your objective, your numbers, your grading of activities. Based on all that, this is your impression of how they're performing. So focus on the most important points that you want people to know. So especially if they're making progress, you really want to put that there to validate why you're continuing to work with them, especially if you're extending them, if you're going to know you're going to be extending them beyond your original, let's say during your evaluation you said you were going to see them for 4 weeks, but you know you're extending them because they're doing so good and they're making those goals, but they need a little more time. You really want to focus on why they need that more time here. And sometimes you will put specific goals here. Like I said, you'll put like what goal, the short-term or the long-term goal that they're really making progress to, or patient has reached long-term goal 1, 2, and 3. Patient will require approximately 2 more weeks to work on the strength and cognition to reach long-term goal number 4. So that's the assessment is a very, very important part, and where the insurance and auditors are going to read why your therapy is needed. Okay, so your A section must be directly related. I talked about that to what you wrote in your S and O sections. So the S and O, the subjective and objective, support your conclusions drawn. So don't contradict yourself in this section. Which you can see a lot if you're not paying attention to what you're writing or just writing too quickly, is if you're contradicting yourself in those S and O versus the A section. If your objective has a max assist for everything and they've been max assist for 2 weeks, but your assessment says they're making great progress towards goals, it can be tricky because they could still be max assist, but in your eyes are making progress due to other small areas that you're just not specifying. So you have to really break it down. And also understand if they're not making goals and if they're plateauing, that P word, that you need to start writing that in the assessment. Patient has been max assist for their goal of upper body addressing with 2 weeks with poor progress with the cognition. I'm trying to think of the specific cognition. The orienting his shirt to dawn over his head, may have to discharge this goal and work on long-term goals 2 and 3, or you might have to discharge your patient if it's a global non-progress. So here's an example of an assessment. Patient demonstrated increased active range of motion in the right upper extremity during ADLs compared to last week, but continues to be limited by pain. Patient is motivated with good family support. Patient would benefit from continued outpatient OT to increase independence with ADLs. Recommend the following equipment. If they need a reacher or whatnot. I would be a little more specific here. So patient demonstrated increased active range of motion in right upper extremity during ADLs. And I know in the objective part you're putting what that is, how much range of motion, but I'd be a little more specific to continue. Or say patient has already increased 20 degrees of shoulder flexion, and with 10 more degrees, suspect independence with upper body dressing, or something like that. But this is also just fine. I really like this one too. So this is a great assessment paragraph. And again, you want to be concise. So if it is very clear in the objective part, you don't have to add what I just said. You just want to make sure it's very clear to your reader who is not an occupational therapist and many times may not have a healthcare background. So you want to think about that. Yes, auditors always do not have sometimes do not have healthcare backgrounds, just to give you a heads up. Another soapbox of mine. Okay, here's some more examples in categories. If you want to break it down into categories, the treatment progress, patient demonstrated increased active range of motion in right upper extremities during ADLs compared to last week, but continues to be limited by pain. So this is just breaking it down. So it's the same paragraph, but you break it down. So depending on how your employer wants you to document, or if you have more freedom, what you're more comfortable with. Just want to make sure you get everything down. And here's an assessment problem list. Problems should be ideally written in order of their significance, which I agree. So a detailed version, so modest is to don a shirt. Broad version is decreased independence with self-care. So which is better? And it just depends on, hold on one second. I think the detailed version is better, but you also have to specify it's the strength. If you did a few specific things, be specific as long as you don't have to write a long list. It's, again, being concise. If you found impairments at every joint, lots of ADLs and transfers and everything, then just be a little more general. If there's so much going on, you can be general. The detailed information should be in your objective section. So you don't need to rewrite your objective in the assessment, which is kind of like what I was saying before. You can be more detailed if there's only specific things, but if it's so broad, so many joint issues or so many cognitive, or all that cognitive range of motion, etc., you need to be a little bit more broad. I hope that makes sense. Again, ask questions. Okay, so that's it with the assessment. We have one more, the plan. So we're almost done with this PowerPoint, guys. Okay, so what is your plan for helping the client achieve his or her goals? So it's exactly what it is, a plan. So it's long and short-term goals, frequency and duration of treatment, suggestions for intervention, discharge plans, including frequency of treatment if appropriate. The plan should be so clear that if you were sick, another therapist could step in and do what you would have done. That is, I love that Dr. Giles included that, because that is so so important and is not practiced enough in the healthcare world. As healthcare professionals, you're going to be helping your coworkers out when they're on sick leave, when they're on maternity leave, when their client base is overloaded and you have a low caseload. You and you don't have an hour to go through all their notes, especially on a crazy day. So you want to be able to look at their treatment note, really quickly look at their evaluation, skim through their last treatment note, and look at that plan. What am I going to do today? It should be easy. It should be right there for you. What are you doing on this next treatment day? Now, yes, a lot of times, we have a plan going into treatment and it doesn't go as planned. But as long as you have that in your back pocket, you can tweak it as needed depending on what happens when you see that client. So if the next plan was to increase patients, you're really working on a shower treatment, and you get to the patient's room or you get to the patient's house, you're like, oh, my wife showered me today, I'm all good. Then okay, what components? You want to know what components of the shower treatment were difficult. Was it getting in and out due to the balance? You can definitely practice just getting in and out of the shower 10 times. And really working on that repetitive transfers is a great treatment, in my opinion, because it just, how the brain works, just the repetitiveness of it. And then, or was it the range of motion in trying to, sit down and reach the feet with the long-handled sponge? You can work on other activities that are related to the shower treatment. So here's an example. Patient will be seen 5 times a week for 1 week to work on safe transfers and toileting. Home program for active range of motion and strengthening right upper extremity will be taught. Patient will transfer to toilet safely with contact guard using walker and grab bars by the end of 5 treatment sessions. What a great plan. So if I walked in there and I had never seen this patient before, I would definitely look over the evaluations, look for any precautionary issues. That's always number one. And so I'm working on safe transfers and toileting. So I need to be working on components of safe transfers and toileting with a walker. Here it is broken down into categories. Again, the other part was a paragraph. Same thing, just broken down into frequency, treatment methods, and goals. And that is it for the SOAP note. I will hopefully get the writing goals, the PowerPoint recorded for you guys too, so you can watch this at your own convenience. Stay safe, everyone, and reach out with anything we can do.